on thyroid gland. We're group 2, together with PGI Antiporda, Paulino, Santos, and me, Villanueva, the clerks, Clerk Guevara, Sura, Sampat, and Murugesa. We're going to report on the anatomy and physiology of the thyroid gland, the adenomatous goiter, the semi-cancerous and cancerous goiters, and the thyroidectomy indications. For the anatomy, Clerk Guevara would report.
Good afternoon to Doc. My name is Clerk Guevara, and let's start this reporting with the anatomy. Now, the thyroid gland is an endocrine structure that is located in the neck that plays a key role in regulating the metabolic rate of the body. The thyroid gland is located in the anterior neck and spans the C5 to T1 vertebrae. It consists of two lobes, which are connected by a central isthmus, and anteriorly, this produces a butterfly-shaped appearance. The lobes of the thyroid gland are wrapped around the cricoid cartilage and superior wings of the trachea. The gland is located within the visceral compartment of the neck, which is along the trachea, esophagus, and pharynx. This compartment is bound by the pretracheal fascia. Next slide po. Now for the embryology, as the tongue grows, the developing thyroid gland descends downward in the neck. It descends anterior to the developing thyroid bone and laryngeal cartilages through the thyroglossal duct. By the 24th day after fertilization, the thyroid gland begins its development. So it is the first endocrine gland to develop. It develops from the endoderm of the floor of the primitive pharynx at the junction of the anterior two-thirds and posterior one-third of the developing tongue, which then develops from the thyroid primordium G. The upper end of duct persists in the dorsum of the tongue as the foramen cecum. The distal part of the duct may persist in 50% of people to form the pyramidal lobe, and it may be attached to the high bone by the fibrous or smooth muscle levator glandulae thyroidea. The thyroid is connected to the developing tongue by a narrow tube called the thyroglossal duct. At first, the thyroid primordium is hollow, but soon it becomes solid and divides into two lobes and is smooth. By the 7th week, the gland takes its final shape and position, and the thyroglossal duct begins to fibrous and degenerate. Now, in some people, the thyroglossal duct um, does not regresses, and usually this regresses at the 10th week of gestation. But if this fails to regress, the thyroglossal duct can give rise to the thyroglossal cyst, which is left untreated. This cyst can become infected and forms a cutaneous fistula discharging out onto the skin of the anterior neck. Next slide po. For the anatomical relations, in the anterior part of the thyroid duct, you can see the infrahyoid muscles, mainly the sternothyroid, the superior belly of the omohyoid, and the sternohyoid. In the lateral aspect of the thyroid gland, you can see the carotid sheath containing the common carotid artery, internal jugular vein, and the vagus nerve. In the medial aspect, you can see the organs such as the larynx, pharynx, trachea, and esophagus, and the nerves. Also, some nerves are also medially located, which is the external laryngeal and recurrent laryngeal nerve. Next slide. Now, for the blood supply, you have two main arteries that supplies the thyroid gland. You have your superior thyroid artery that arises as the first branch of the external carotid artery. It lies in close proximity to the external branch of the superior laryngeal nerve that innervates the larynx. Second is your inferior thyroid artery that arises from the thyrocervical trunk, which is a branch of this very current laryngeal nerve that innervates also the larynx. Now, there are some people, around 10% of the population, has an extra artery in the thyroid, which is your thyroid eye and a artery that arises from the brachiocephalic trunk and supplies the anterior surface and isthmus of the thyroid gland. For your venous drainage, this is carried by the superior, middle, and inferior thyroid veins, which forms a venous plexus around the thyroid gland. The superior and middle vein drains into the internal jugular vein, and the inferior empties into the brachiocephalic vein. Next slide. For your innervations, the thyroid gland is innervated by branches derived from the sympathetic trunk. Although these nerves do not control the secretory function of the gland, hence the release of the thyroid hormones is still regulated by the pituitary gland. The lymphatic drainage is through the paratracheal and deep cervical node. In clinical significance, the left and right recurrent laryngeal nerve lie in close proximity to the thyroid gland, and care must be taken not to damage these during thyroid surgery. That they branch from their respective vagus nerve within the chest and hook around the right subclavian artery from right to left nerve, or the arc of aorta, which is from left to right nerve. The recurrent laryngeal nerve then travels back up the neck, running between the trachea and esophagus in the esophageal groove. Then it then passes underneath the thyroid gland to innervate the thyroid. Next step.
So for the physiology of the thyroid hormones are thyroxine, also called T4, and thiiodothyronine are T3. They are tyrosine-based, containing hormones that help regulate our body's metabolism. T3 and T4 are produced by the thyroid gland, and if we take a cross-section of the thyroid gland, we will see thousands of follicles which are lined by follicular cells. Follicular cells are bipolar cells with an apical side that surrounds the central cavity or lumen filled with colloid, which is the lumen that contains the precursor molecule thyroglobulin. Thyroglobulin is a large glycoprotein that is synthesized by the follicular cells, and then it is secreted into the lumen of the follicle to be stored in the colloid. The basolateral membrane, which is in contact with the blood vessels, contain the sodium iodide symporter, which pumps 2 sodium ions into the cell down their electrochemical gradient in order to bring 1 iodide into the cell. Iodide is then pumped into the colloid through pendrin. Once iodide is in the colloid, it undergoes oxygenation through the enzyme thyroperoxidase, which changes it into iodine atom. It's then attached to tyrosine amino residues, which are found throughout the thyroglobulin. This process is called iodination. So some tyrosine residues are bound by only 1 iodine atom, while some are bound by 2 yielding monoiodotyrosine or MIT and diiodotyrosine or DIT respectively. These molecules are linked together by thyroperoxidase. Linking 1 MIT and 1 DIT creates T3, while linking 2 DITs creates T4, and both T3 and T4 remain bound to thyroglobulin. When the follicular cells are ready to secrete T3 and T4, they endocytose thyroglobulin into a vesicle, which then fuses with the lysosome. Here, thyroglobulin is cleaved by proteases, and T3 and T4 are released into the bloodstream. Production and secretion of thyroid hormone is under control of the HPA axis. Hypothalamus secretes thyroid-releasing hormone or TRH into the hypothalamo-hypophyseal portal system. In the anterior pituitary, TRH binds to thyroid cells and stimulates them to release the hormone thyrotropin, also called thyroid-stimulating hormone, into the bloodstream. The TSH then binds to the thyroid gland and binds to receptors located in the follicular cells of the thyroid gland. Once hormones are released from the thyroid gland, T3 and T4 enter the blood and bind to proteins. The most important one is the TBG, or thyroxine binding globulin. But they also bind to albumin and transthyretin, biologically active. 3% of T3, and this fraction is biologically active. Once inside the cell, T4 is converted into T3 by the enzyme 5-deiodinase. T3 helps to speed up the basal metabolic rate. So as an example, exposure to cold weather stimulates the release of T3 and T4, and they go on to increase body's metabolism and heat production. They also activate the sympathetic nervous system, which is responsible for fight and flight response. This increases cardiac output, respiratory rate, and mental alertness. They also work synergistically with growth hormone to promote long bone growth and are necessary for brain development. So for all of this to work properly, thyroid hormones have to stay within the normal range. In order to do that, the body uses negative feedback. This means when the thyroid hormones are low, the hypothalamus and pituitary gland increase their secretion of TRH and TSH respectively, and the thyroid gland gets more stimulated to produce thyroid hormones, and eventually T3 and T4 hormones will go back up to the normal range.
Oh, yeah, I have a few questions muna before we go on to the next lecturers. Are you done with physiology part, Dr.
Yes.
Okay. I have let's go back to anatomy. Our anatomy representative, reporter, I mean.
Yes, to that.
Yes, good afternoon.
Yes.
You mentioned the anatomy of the thyroid, right? I was not able to hear anything on the thyroid, on the recurrent laryngeal nerves, which is very important in terms of surgery, What can you say about the recurrent laryngeal nerves, right and left?
Come again to that.
Can you discuss a little on the recurrent laryngeal nerves?
Okay po. In clinical significance po, the left and right laryngeal nerves they lie in close proximity to the thyroid gland. Because of this, doc, when doing the surgery, we should be able to distinguish the recurrent laryngeal nerve, because if we are to damage this food, the recurrent laryngeal nerve may the injury that the injuring the recurrent laryngeal nerves may cause a vocal cord paresis, resulting in voice changes or hoarseness to the patient.
Okay, so where do they come from? What's the root?
They branch from their respective vagus nerve po, within
Okay.
which is
What else? What else branches from the vagus nerve?
the right
That
subclavian
is also very important.
the right subclavian artery and the arc of
No.
aorta.
We're talking about the nerve, doctor. Just the nerve. It's there in your picture.
Doc, the superior larynx.
Okay, very good. So two very important nerves come from the vagus nerve, the recurrent laryngeal and the superior laryngeal. Why is it called recurrent? Why is it called recurrent? Recurrent laryngeal nerves. Are you checking Google, doctor?
I'm sorry po. Yes po.
Do not do that, please. Do not insult your classmates by doing that. It's enough for you to say you don't know, and I will tell you why. But do not ever do that. Understand, doctor?
Yes po, Doc. Sorry po.
Okay, going back to my question. Why is it called the recurrent laryngeal nerve?
I was not able to read through that. Why?
You don't know. Okay. It is because it loops around twice. From the vagus nerve, it comes down. And then it will loop underneath your bronchus. And then it will go back up before it enters into your larynx. That is why that is a recurrent. At any one point, may dalawang the same nerve na umiikot. It loops around. That's why it's called the recurrent laryngeal. How significant is that? Anywhere along that loop, that very long loop, any injury to that nerve could cause paralysis. So even TB can cause paralysis because it loops at the bronchus, di ba? It loops at the bronchus on the left, and then, if I'm not mistaken, the subclavian artery on the right. So the bronchus on the left, if you have a TB around that area, even at the superior lobe, which can irritate the nerve, which can cause paralysis. Kaya sometimes patients with TB will present with hoarseness. Okay? My second question is, how do you compare the right from the left recurrent laryngeal nerves? In terms of anatomical position, where is it located?
Thank you, Dr.
Again, you do not know. That is what you should have been reporting. It is found in the tracheoesophageal groove, right and left. Which is more lateral? The right or the left?
Doc, the right.
The right. Okay, correct. Why? Because it loops at the brachiocephalic artery, diba? From the aorta. Therefore, it is more lateral on the right compared to the left. About 1.5 centimeter from the trachea. Then about another 1 cm on the left. Last question. What about the pyramidal lobe?
Doc?
What about the pyramidal lobe? Did you come across the pyramidal lobe?
I only mentioned it, but I did not read on it further.
What is the pyramidal lobe? Anybody who can help? The pyramidal lobe is an undescended part of the isthmus that has separated, or it can be separated, it can be connected to the isthmus that has not descended to its correct position. which is at the trachea, at levels, what level, what rings? What tracheal rings is the isthmus found? Tracheal rings 2 to 4. The pyramidal lobe is either undescended, separate, or connected. Now, there is a condition called thyroglossal duct cyst. Now, thyroglossal duct cyst, it is intimately related to the pyramidal lobe. Now, what makes surgery, because usually we remove the thyroglossal duct cyst, correct? But what is a caveat that you have to remember regarding that? The caveat there is, what if it has not completely descended at all? There is no thyroid in the right, left, or in the isthmus. It is just that pyramidal lobe. That is why it is very important you do a thyroid ultrasound to make sure that you have other thyroid gland in its proper place, or else when you remove the thyroglossal duct cyst, you're actually performing a total thyroidectomy, rendering your patient requiring to have hormone supplementation for the rest of his life. Okay? Hello, doctor? Are you still there?
Yes po, Doc.
Okay? So that is yun lang yung kulang sa report mo. Ano?
Yes po, Doc. Noted po. Thank you.
Sige. Okay, thank you. Let us go on to physiology. Doctora, where is Doctora?
Ito po, Doc.
Okay. Doctora, you mentioned a while ago there is such a thing as T3 and T4, unbound and bound, correct?
Yes po, Doc.
Okay, which is more, unbound or bound?
More bound po is T4 because it's affinity po sa mga proteins po such as TBG po.
Okay. I have a few questions.
Tapos,
sige, keep going.
tas,
Go ahead.
yung higher po yung unbound po for T3 po. Since yun nga po, yung T4 po sa higher po sa bound.
Okay. So have you heard of the laboratory test free T3 and free T4? Is that the same as unbound T3 and unbound T4?
No po, Doc.
Are you sure?
I'm not that sure, Doc.
How about your classmates? Is it the same? Free T3 and free T4 is not the same as unbound T3 and unbound T4.
Same po. Same.
Correct. It is the same. Okay. So, since there is more unbound T3, unbound T4 versus bound T3 and bound T4, more probably, if you are to measure the unbound number, it will be more accurate compared to the simple bound T3, T4. That is why we prefer between T3 and T4, we ask for free T3, free T4. Okay, in laboratory, when you ask for your laboratories. Okay, okay. Next question. I'll give you an example of an actual patient. Patient comes in, complains of palpitations and exophthalmos, and then you do a thyroid profile test. You ask for a TSH, free T3, and a free T4. The results are TSH 0.04, free T3 22, free T4 68. What is the diagnosis and why?
Hyperthyroidism po, Doc.
Okay, why?
or goiter po.
Now you don't know that yet.
Since
Just based on that.
according to the laboratory findings po, the TSH levels are low po, and the free T3 and T4 po are high po.
Okay, using what you discussed a while ago in terms of physiology, how would you explain that? Why are those numbers like that?
Wait, ano po yung ulit to?
Why are the numbers like that? Pagka meron kang hyperthyroidism. Sobrang baba ng TSH,
there is
sobrang taas ng free T3, free T4.
There is excess po of iodine production po. Excess of iodine production po leads to increased T3 and T4. If there is increased T3 and T4, there will be negative feedback mechanism po, which leads to decreased TSH levels po.
Okay, the negative feedback will tell the brain to stop telling the thyroid to produce, because there is so much already in the blood. This is all done in the hypothalamus, as you reported a while ago. Okay, very good. Ganun yun, ha? O, what if the TSH is 25, free T3 17, free T4 is 32? What is that? I know, free T4 is 3. Yan. Tapos free T3, 2. Sabihin natin. Pero your TSH is 35. Oh, ilan na? Ano yun?
Hypothyroid.
Why? Explain it in terms of physiology.
If there is less iodine production po, it leads to decreased T3 and T4 po, and which creates negative feedback po to the hypothalamus. And
How does that work?
Secretes increased
How does that work
TSH.
as a negative feedback?
Positive.
Negative feedback?
Positive feedback.
Positive feedback naman. Explain.
Positive feedback.
So what is the response of the body?
The body's response po is to increase the TSH and TSH levels po from the hypothalamus po.
Okay. Again, the brain picks up
it will
the fact.
Stimulate more production.
Yes. The brain picks up the fact na mababa ang T3, T4 mo in the blood. It will tell the hypothalamus, the hypothalamus will secrete TSH to tell the thyroid to produce more. Correct? Pero,
yes,
because chronically, hindi siya nagpo-produce more, bigay ng bigay si pituitary ng TSH. Kaya mataas ang levels ng TSH sa blood. That is how you diagnose. You diagnose because you understand the mechanism. It is not because of a certain number falls at a certain range. Just because mababa, tapos mataas, automatic, hyperthyroid na daw yun, etc. Ano, doctor? Yes. You have to understand the physiology so that you will be able to diagnose properly. Ang mahirap dyan, kung mix na yan. Kung yung sinasabi nating subclinical hypothyroidism, subclinical hyperthyroidism, normal yung TSH mo, pero mataas o mababa yung free T3, free T4 mo. Pagka ganoon, anong gagawin natin? Mag-refer na sa IM endocrinologist. Okay? Alright?
Yes.
O, sige. Okay. Your classmates, do you have any questions? So we can move on to the next topics. Okay, go ahead with the next lecture.
First, so I will be working with Thyroid. So together with Clerk Morales and Sajid. So basically, adenomatous goiter has an accompanying tumor formation due to the overgrowth of the cells of the thyroid tissue. So this is nodular goiter is used frequently by pathologists and surgeons as a synonym for adenomatous goiter. And these are usually benign. These nodules are usually benign. And also in the figure, we can see the morphologic feature of nodular goiter, in which in the upper left figure, we can see that there is a nodularity. There is also in the upper right, we can see fibrous scarring. And there is also presence of hemorrhages and focal calcification and cystic degeneration. Because nodular goiter is regarded as the end stage of long-standing simple goiter. So it is characterized by most extreme degree of of tumor-like enlargement of the thyroid gland and with characteristic nodularity. Next slide, please. We go now to the diagnosis. So the diagnosis, the following diagnostic tests are usually a tool in ruling out malignant nodules of the thyroid. So first, when we should see the clinical assessment and the history and physical examination. So we should consider the age and the gender. So nodular disease is more common in older patients and also in more common in women age 50 years or older. And family history of, we should see if there's family history of any thyroid carcinoma. And then if there is history of previous head and neck radiation exposure, because this will significantly increase the risk of malignancy in patients with a thyroid nodule. And for the symptoms, throat or neck pain is rarely associated with carcinoma, but frequently occurs with hemorrhage into a benign nodule. So for the PE, we should take note of the size, shape, consistency, and tenderness of the thyroid gland, and also the involvement of the trachea if there is any deviation, and also for the if there is for the tumor fixation. Next slide, please. So for the laboratory studies, we do the thyroid function test, which is a thyroid stimulating hormone. So this is an excellent screening test, and this usually comes with and full thyroid function test can be performed if the TSH level is abnormal, like measuring of thyroglobulin, which is not generally performed, but if because it will not differentiate between benign and malignant process. But if the levels of thyroglobulin are high, this will usually indicate metastatic thyroid cancer. For the serum calcitonin levels, These are not typical initial tests for patients with a thyroid nodule unless the patient has a family history of any thyroid carcinoma. And this serum calcium level should be measured to exclude any hyperparathyroidism. Next slide, please. So we go now to fine needle aspiration cytology. So this is the procedure of choice in the evaluation of any thyroid nodules. So it is it has a highly sensitive and specific result, and although the accuracy of this fine needle aspiration cytology is related to the skill of the aspirator and also the cytopathologists. So this with the advent of this technique, the number of patients required surgery has decreased up to 35 to 75%, and the cost in managing patients with thyroid nodules has been substantially reduced. And 60% to 90% of nodules usually are benign, and 1 to 6% of the thyroid nodules in the FMAP usually has likelihood of malignancy. Next slide, please. So for the technique, this is done with the patient placed in a supine position with a pillow under the shoulder for to hyperextend the neck and instruct the patient not to move or not to swallow. So the nodule is fixed by immobilizing it with the 2 fingers. And local anesthesia may or may not be used because in here, the needle used is usually thin, which is 23 to 25 gauge needle. And the needle will move rapidly to and fro the same needle track, and then the specimen is expressed on the slides that will undergo into histologic studies. Next slide, please. So for the imaging, ultrasonography is useful and sensitive. These studies detect non-palpable nodules and differentiate between cystic and solid nodules, as seen in the figure. So usually, cystic nodules will seen as anechoic, meaning in the figure, if you can see the black one, that is an anechoic type of nodule, and this is usually cystic, while solid nodules usually are hyperechoic or isoechoic. And also ultrasound will determine the nodule size and architecture. And this ultrasound guidance and fine needle aspiration cytology has become integral to the initial workup and has resulted improved selection and target selection and diagnostic field. So next, please. Next one is computed tomography and MRI scans. So these are usually unnecessary in the evaluation of thyroid tumors, except for fixed or substernal lesions, because this will visual focus for any involvement. Although these studies are not as effective as ultrasound in the evaluation of thyroid nodules, they are more reliable in evaluating relationship of the thyroid lesion to adjacent neck structures. And MRI is more accurate than CT scan in distinguishing recurrent or persistent thyroid nodule. Next slide, please. Next one is the thyroid isotope scanning. So this usually uses radionuclide scanning with iodine 123 or technetium 99M, system B. And in here, nodules that this will usually determine the function of the nodule. So if the is non-functioning and hypofunctional, so this is usually called nodule, as seen in the figure above. And if the nodule is producing too much hormone, it will show up darker, and it is called the hot nodule, as seen below the cold nodule. So hot nodules are usually benign, and cold nodule are usually more on malignant one than benign. And nodules that and cold nodules are retain less radioactivity than the surrounding thyroid tissue. Next slide, please. So for the treatment, it will be reported by my
treatment. Next slide, please. Rational approach to management of the thyroid nodule. First, observation, then medication, surgery, and radioactive iodine. Evaluation generally begins with thorough history and physical examination. Initial workup is by TSH screening, fine needle aspiration cytology, and ultrasonography. In carcinoma, surgery should be considered. In follicular neoplasm, increased TSH, surgery is done. Whereas in decreased TSH level, radionucleotide scan is done. If it is cold, surgery is done. If it is hot, evaluate and treat for thyrotoxicosis. In benign condition, observe. If nodules grow, consider surgery. In indeterminate cytology, it may require repeat FNAC. Next slide, please. Observation is done if the goiter or nodule is small and does not cause any problem. Medications like thyroid hormone replacement is given in conditions like hyperthyroidism. Surgery is done like total or partial thyroidectomy. Total thyroidectomy is removing of entire thyroid gland, and partial thyroidectomy is removing the part of thyroid gland. Next slide, please. Radioactive iodine is considered if it is an overactive thyroid gland, used to treat hyperthyroidism and delivered as oral capsules. That's it.
Okay, hold on. We have a few questions for the group. Okay, I have a few questions. I have a question for who is Atik Khan?
Yes, Product.
Atik Khan. Okay. Why are you not? Where is your camera, sir? Turn your camera on, please, Mr. Khan, Dr. Khan.
It's on, Product.
Is this you? Is that you?
Yes, Product.
Okay. Where were you a while ago? I was looking through your camera was off the whole time your colleague was reporting.
Doc, it was on for Doc.
Uh-huh.
I don't know what happened, so I just shifted my lecture from my phone to my iPad, so that's why I can access it now.
All right. Because there are a few of you who are not on. Your cameras are off.
Oh,
How
I'm
do
so
I know
sorry
you are
about that.
here? How do I know the rest of you are here? Like Premjit and Ralph Erickson and Akash Patil. Where are you, doctors? Please show yourselves. Dr. Khan, are you going to report also?
No, Doc.
No. Okay. I'll start my questioning with you, Dr. Khan. According to the
Yes.
report of your classmate, what is the contents of an adenomatous goiter nodule? Where are you? Yes. Dr. Khan, I cannot see you again. I only see your
Doc, I'm
forehead.
right here.
I only see your forehead. Lower your camera so I can see what you're doing.
Just a minute, Doc.
You see, all doctors. Since we are doing this because we cannot do face to face, I do not know if you really are with us. So I was scanning a while ago, and I did not see Dr. Khan's face. Okay, Dr. Khan, back to my question. According to your classmate who gave her report, a very nice report if you ask me, what was the contents of an adenomatous goiter?
I'm not sure, Doc.
Okay. Maybe go back to the reporter. Doctora, the last one. Yes, who gave the oh no, sorry, the first one, the one who reported on the adenomatous goiter.
Yes, po, Doc.
Okay, Doctora, what would you say is the content of a adenomatous goiter?
Histologically, Doc, the content of the
Yes.
adenomatous goiter are usually high colloid to cell ratio, Doc. And it usually
Good.
consists of Hertel cells, Doc, which are basically enlarged follicles, Doc.
Okay, Hurtle cells and high colloid
Colloid.
versus cells. Did you get that, Dr. Khan?
Doc, could you just repeat that, please? I couldn't hear properly.
Your classmate, please repeat it for the benefit of Dr. Khan.
Usually adenomatous goiters histologically contains high colloid cell and Hertel cells, which are basically enlarged follicles.
So when you do a biopsy of that adenomatous goiter, colloid or whatever, you expect to see colloid cells, Hurtle cells. What else, Doctora? Some other cells in the report, correct? Do you find cancer cells?
Usually, Doc, in adenomatous goiters, we don't see cancer cells because usually are benign, Doc.
Yes, these are all benign. So you will not see cancer cells in a histopath of an adenomatous goiter. Because if you do see that is no longer adenomatous, that is cancerous or semi-cancerous already. Okay, Doctora? Very good, Doctora. May I have the second one, the last one to report for the management?
Yes, sir.
Okay. Okay. Doctora, uh, you said that, what is your source for this approach to the
Doc,
management of the thyroid nodule? Where did
Doc
you get this?
Cummings
Cummings?
otolaryngology. Doc.
Very good. I expected as such. But also, mind you, there is also a AA, it's this American Thyroid Society. They also have a algorithm that we use more for surgery rather than this. So nice to know. You can look it up, the American Thyroid Society algorithm for goiter, and you will see that it is quite similar to this, but more surgically inclined.
Okay.
Okay, doctor? All right.
Okay, Doc.
Now, my question is, Doctora, what is
Okay, Doc.
the management, the actual management of adenomatous goiter of the right lobe?
Doc, light.
Right. What do you do if you have an adenomatous goiter that is, say, 4 centimeters in size, found only in the right lobe? Assuming your hormones are normal, what is the management for something like that?
Doc, we need to observe, and if nodules grows, we need to consider for surgery, Doc.
Okay, what kind of surgery will we do?
Partial thyroidectomy, Doc.
How do you do a partial thyroidectomy? What do you remove? That's my question, actually. I'm sorry. What do you remove in a partial thyroidectomy? Do you remove just the mass or the whole lobe, or the mass, the lobe plus the isthmus? What do you do?
Doc, just the mass, Doc.
Okay. I beg to differ, Doctora. When you have an adenomatous goiter, you remove the entire lobe,
Okay, Doc.
not just the mass. Okay.
Okay, Doc.
We also include the isthmus.
Okay.
We leave the unaffected side. Okay.
Okay. Okay, Doc.
Okay. Thank you. Let us go ahead with the next lecture. Keep going. Semi-cancerous and cancerous goiters.
Good evening, doctors. So we're going to report semi-cancerous and cancerous goiter. I'm PGI Antiporda, and together with Clerk Sampat, we are going to report about thyroid neoplasm. So first, we're going to discuss the thyroid neoplasm, thyroid adenoma. So usually, it is a true benign neoplasm which is derived from follicular cells. They occur mostly common in women older than 30 years old. So usually here the patient presents with solitary mobile thyroid nodule with a painless mass. So if this mass enlarged, this may produce local symptoms such as difficulty of swallowing, and then sudden hemorrhage into the adenoma may cause a sudden increase in size and associated with pain. Next, let's discuss about the pathology of this thyroid adenoma. Thyroid adenoma, as you can see in the picture A, so this is a solitary in gross microscopic, a solitary well circumscribed nodule is seen. The classic adenoma is fleshy, pale, and all through areas of necrosis, hemorrhage, and cystic change. And then in the next picture, letter B, so the photomicrograph show well-differentiated follicles resembling a normal thyroid parenchyma. So this thyroid adenoma have histological classification, which is the follicular adenoma and rare tumors. follicular adenoma are the most benign thyroid lesion. It have a characteristic of excess cellularity and mitotic figures or necrotic foci. So the management for this thyroid adenoma, according to the American Thyroid Association guideline, it is recommended for serial clinical examination of easily palpable benign nodule at 6 to 18 month interval. If the fine needle aspiration cytology will show follicular neoplasm, surgical evaluation is needed. We can do surgical excision or thyroid lobectomy if the patient have history of radiation, head and neck, and other neck cancer, and if the patient is having high risk factor and comorbidity. We can also do surgery and radioiodine therapy if the lesion is greater than 3 centimeters. Next slide, please. So next, we're going to discuss about the thyroid cyst. So usually this thyroid cyst is non-specific diagnosis, but this is a frequent entity which we usually encounter in clinical practices. 15 to 25% of these thyroid nodules are cystic or have cystic component. The presence of cyst does not signify benign lesion because usually carcinoma also manifests cystic masses. If we encounter this thyroid cyst in fine needle aspiration cytology, what we can do for the management is drainage, although 1 or 2 additional drainage procedure may be required. If cyst persists after 3 drainage attempts, we can do thyroidectomy. Next slide, please. We're going to move in the thyroid carcinoma. So thyroid carcinoma, there are 2 types of epithelial cell in the thyroid from which primary carcinoma can arise. The first one is follicular cell and the second one is parafollicular cell. There are 4 major subtypes of thyroid carcinoma. The first one is papillary thyroid carcinoma, which consists of 80 to 85%. For second one is follicular carcinoma, which consists of 10 to 15%. The third one is medullary carcinoma, which consists of 5%, poorly differentiated, and anaplastic carcinoma, which consists of less than 5%. So the important thing in this slide is that all of the thyroid carcinoma arise from follicular cell except the medullary carcinoma cell, which arises from parafollicular cell or C cell. Next slide, please. First, we're going to discuss the papillary carcinoma. So this is the most common form of malignancy. This is predominant thyroid malignancy in children, which is 75%. This is also seen in history of low radiation exposure, and the lesion of this patient typically seen in 30 to 40 years old. Papillary carcinoma usually present as asymptomatic thyroid nodule, but the first manifestation may be mass in cervical lymph node. So most of the carcinoma are single nodule that is freely movable with the thyroid gland during swallowing. So if there is a presence of hoarseness, dysphagia, cough, or dyspnea, it means that there's an advanced disease. So this papillary carcinoma is classified into 3 categories based on the size and extent of the primary lesion. The first one is minimal carcinoma or occult carcinoma. So this is usually 1.5 to non-palpable and there's no invasiveness. The second one is intrathyroid tumor, which is greater than 1.5 centimeter, which is confined in a thyroid gland, but no extrathyroid invasion. The third one is the extrathyroid tumor, which involve the surrounding viscera. For the pathology, gross examination, let's discuss the picture A. So in picture A, there's the appearance of the papillary carcinoma with grossly discernible papillary structure. Papillary carcinoma is fibroid and not encapsulated. In the picture B, this is an example of contained well-defined form papillae. In the C pictures, cells shows the characteristic of empty appearing cell, which is called orphan eye nuclei. And then in the D picture, it shows intracellular inclusions. There is also the presence of samoma body hairs, which is laminated calcium densities. So the most important here in the pathology in this papillary carcinoma is the presence of orphan eye nuclei, and then the samoma bodies. So it have also a histologic variance, which is the follicular, tall cell, and columnar cell variant. There's also another one, which is the diffuse sclerosing variant. So what's the important in histologic variant? Follicular is usually have good prognosis. Tall and columnar cell have bad prognosis. So the characteristic of tall cell is usually eosinophilic cytoplasm, and it is aggressive. While the columnar, it is the presence of nuclear stratification. The diffuse sclerotic variant, it is occur in younger patient. For the management of this carcinoma, first one is the unilateral lobectomy and ischiotomy. It is usually sufficient surgical treatment if there's no angioinvasion. So for total lobectomy, this is indicated in patient with small encapsulated papillary carcinoma. So total or near total thyroidectomy procedure is a choice when the patient present with a biopsy-proven disease or indication of disease in both lobes. Next slide, please. Next is the follicular carcinoma, which is the second most 10% of the thyroid malignancy. So it presents in 50 years old, compared with the papillary, which is 35 years old. The lesion occur more frequently in iodine deficient area. The patient usually present with solitary thyroid nodule. These lesions are typically painless, but hemorrhage into the nodule may cause pain. For the pathology, in the picture, letter A, so the tumor has a light tan appearance and contains small foci of hemorrhage. Picture B, few of the granular lumen contain a recognizable colloid. Follicular carcinoma have two category, which is minimally invasive. It do not exhibit small vessel invasion, while the second one, frankly invasive tumor, it exhibit vascular invasion. For the management of this follicular carcinoma, thyroid lobectomy with ischiotomy is performed if the patient is diagnosed with it by fine needle aspiration cytology. A total thyroidectomy is recommended if carcinoma is identified and if it is performed in older patient with a nodule greater than 4 centimeter. It is also recommended if the patient have family history of thyroid carcinoma and if the patient is having history of radiation exposure. Neck dissection is performed if cervical lymphadenopathy is present. The thyroid follicular carcinoma have another variant, which is the subtype Hertel cell. As you can see on the photo, that's the example of Hertel cell microscopically. So this usually found in Hashimoto thyroiditis or Graves' disease or within the nodular goiter. These tumors are derived from oxyphilic cells of the thyroid gland. So Hertel cell carcinoma are more aggressive than follicular carcinoma and are often multifocal and bilateral at presentation. Next slide, please. Next one is the medullary carcinoma. Medullary carcinoma is approximately 5%. So as I was saying a while ago, this is the only malignant thyroid carcinoma that arises from parafollicular cell or C cell. So here usually the patient present with a neck mass associated with palpable cervical lymphadenopathy. So if there's a local pain is common if there's a patient indicate the presence of local invasion, which may associated with dysphagia, dyspnea, and dysphonia. So this medullary thyroid carcinoma, is associated with MEN syndrome or MEN 2A and MEN 2B. In pathology, for macroscopic examination, letter A, so the tumor typically shows solid pattern of growth and do not have connective tissue capsule. In letter B, it demonstrates abundant deposition of amyloid, visible here as homogeneous extracellular material derived from calcitonin secreted by the neoplastic cell. For the management, total thyroidectomy is the treatment of choice in patients with MTC because of the lesion have high incidence of multicentricity and aggressive disease. So if the patient also have familial history and the presence of MEN2, and if the patient is 2 to 3 years old, total thyroidectomy is the choice. Bilateral center compartment neck dissection is the initial surgical management should include because of the frequent involvement of the surgical lymph node. Ipsilateral or bilateral comprehensive neck dissection when the central compartment of the nodes are involved or there is a palpable lateral cervical nodes are present. Elective ipsilateral comprehensive neck dissection when the primary lesion is greater than 1 centimeter. Next slide, please. The next one is the anaplastic carcinoma. So the characteristic of this anaplastic carcinoma, it is one of the most fatal malignancy. The patient have survival of 6 to 12 months. And usually, it typically the patient typically present with a long-standing neck mass. The classic presentation, it enlarged rapidly. So sudden change is often accompanied by pain, dysphonia, dysphagia, and dyspnea. So often the mass is quite large, is fixed and tracheolaryngeal framework and result of vocal cord paralysis and tracheal compression. In gross anatomy examination of this one, in pathology, it shows firm and infiltrates the surrounding structure. There's no discernible thyroid shape. And then for the microscopic, letter D, anaplastic carcinoma demonstrate variable morphology such as large pleomorphic giant cell. Second one is spindle cell with sarcomatous appearance and mixed spindle cell and giant cell. For the management, usually this case is extremely difficult and required multidisciplinary approach. Surgical resection may be considered if local regional disease can be resected with grossly negative margin. One current treatment protocol involves doxorubicin, hyperfraction, radiation therapy, and potential surgical debulking. Next slide, please. So the other forms of thyroid carcinoma will be reported by Clerk Sama. Doc Sama.
Now let's move on to other forms of thyroid carcinoma. Now let's see lymphoma. For the clinical presentation of lymphoma, it's common in patients older than 50 years old, and we can see painless enlarging mass with the regional adenopathy, dysphagia, vocal cord paralysis. For primary thyroid lymphoma is unusual and represents less than 5% of the thyroid malignancies. With a ratio of 3:1, it occurs more in women than in men. The ratio of 3:1. It manifests in patients with presence with symptoms similar to anaphylactic carcinoma, although rapidly enlarging mass is often painless. Symptoms includes adenopathy, dysphagia, and vocal cord paralysis. For the pathology, it is generalized lymphomatous condition because it's common in patients who are receiving already thyroid replacement therapy for conditions such as Hashimoto disease. And for the management, chemotherapy with combination of CHOP, combined radiation chemotherapy were used. For the prognosis of this, it's based on the histology grade of the tumor and the presence of extra thyroid disease. Overall, 5-year survival rate is about 50%. In intrathyroid disease, survival is about 80%, and for the extrathyroid disease, it decreases to 40% per patients. Next slide, please. Now, insular thyroid carcinoma. For the clinical presentation of this, it is independent lesions or concomitant with the papillary or follicular thyroid carcinoma. It is aggressive if it is independent. Like insular carcinoma, if it is located within follicular and the papillary thyroid carcinoma, it does not seem to affect the clinical course. But if it is alone, it is mortality is increased. For the treatment, radio iodine therapy is used. Next. Now, metastatic carcinoma. Its clinical presentation is almost variable and depends on the organs involved. Metastasis occurs from primary lesions in kidneys, breast, lungs, or skins. Its pathology varies based on the organ involved for metastasis. For the management of this, it depends on the type of cancer, whether we use surgery.
He will ask after this.
Whether we use surgery, chemotherapy, or the hormonotherapy, or thyroidectomy. And the next. Then squamous cell carcinoma. It's less than 1% common. It's older patients are more commonly affected. It's malignant with poor prognosis. For the management of this, early detection and the surgical management is suggested. Radiation therapy is used. Next.
Is that the end of your report, doctor?
Yes.
Yes, sir.
Okay. I have a few questions for the last two who reported. Can we go to the first one? One on cancerous thyroid nodules. Hello?
Hello,
Doctora, I have a few questions for you. First question is, what is common among all of those cancers?
Doc?
What is common among all those cancers that you described a while ago?
Usually, Doc, it presents with a cyst or it's in a mass in the thyroid foot.
Okay, be a little more specific. What can you say about the management? Let's go to management and the cancers you mentioned. What is common among all of them?
Chemo.
Correct. It is not surgery alone that you treat these cancers, okay? You have to include either chemo or radiotherapy. Now, when it comes to the surgery, what kind of surgery did you see that is common among all those cancers you mentioned?
Total thyroidectomy.
Correct. Again, you are talking of total thyroidectomy even if it is only found in one lobe. Okay? Another very important note. Why? What is common again in the kind of surgeries we do for those cancers? Aside from doing total thyroidectomy.
Follow up po, Doc, like test follow-up po after post-operation.
Intra-op muna tayo, doktora.
Okay.
What is common? Aside from doing a total thyroidectomy.
The patient need to assess fine needle aspiration cytology po before total thyroidectomy.
That's already done. You're already doing surgery, doctora. You already did a total thyroidectomy. What is the next thing that we do for all those surgeries, for all those cancers? You mentioned it a while ago. What, doctor?
Lobectomy, doc.
Not only you're already doing a total thyroidectomy, so you remove all the lobes. What else?
Doc, central
What
neck
else
dissection.
do we do? Correct, Dora. Aside from doing total thyroidectomy, the commonality among all those things is you also do a neck dissection. What kind? That depends on how it or it depends again if it is loco-regional only or if you have metastases, whether you do neck dissection or not. But the point is, when you have cancer of the thyroid, you do at the very least a total thyroidectomy and a neck dissection. Okay? Okay, very comprehensive, I like. All right, for the second lecture, Doctor,
Yes, doc.
I have a question for you.
Yes.
What you mentioned a while ago is not so common cancers of the thyroid,
Yes,
correct?
doc.
These are your lymphomas, your squamous cell carcinomas, etc. My question is, are these inherent or do these arise from the thyroid itself?
No, doc.
Correct. These do not arise from the thyroid itself. These are extensionary cancers coming from somewhere else that has invaded the thyroid and now affecting the thyroid. That is the only difference between the thyroid carcinomas lectured a while ago and what you lectured just now. Okay, Doctor? So do not be confused. These are extension cancers for somewhere else. Usually the larynx going into the thyroid. Okay? But there are also cases, papillary thyroid carcinoma that is punched into the larynx. I've seen it. I've had a patient like that. Okay? Okay, let us go on thyroidectomy now. The next lecture, please.
Good evening, doctors. Together with Clerk Sura, we will report on thyroidectomy. First, what are the indications for thyroidectomy? According to the American Thyroid Association, there are four. First, if there is a thyroid nodule, that can be thyroid cancer. Second, if the patient was diagnosed with thyroid cancer. And third, if the nodule or goiter causes local symptoms, such as compression of the trachea, dysphagia, or a visible or unsightly mass. And lastly, if the nodule or goiter causes symptoms due to the production and release of excess thyroid hormone. For the kinds of thyroidectomy, Clerk Sura would report.
Good evening, Doc. This is Sura. I'm going to discuss about the kinds of thyroidectomy. These are types of thyroidectomy. First one is the thyroid lobectomy, which is also called as the partial thyroidectomy, isthmectomy, total thyroidectomy, subtotal thyroidectomy, near total thyroidectomy, and the last procedure is the Hartley Dunhill procedure. Next, please. Thyroid lobectomy. In this case, in this procedure, the total lobe will be removed for the patients with small papillary tumors located on only one lobe of the thyroid gland and whose cancer hasn't spread outside the thyroid lobe. In these types of patients, the thyroid lobectomy or the partial thyroidectomy will be done. This means in the thyroid lobectomy, only the cancerous thyroid lobe will be removed. Unlike the total thyroidectomy, this procedure won't result in the hyperthyroidism. Though one lobe is removed, the remaining lobe can still produce the healthy amounts of thyroid hormone. Most importantly, because other side of the thyroid is untouched, there will be no risk for the both parathyroid glands, recurrent laryngeal nerve, and the external branch of the superior laryngeal nerve. Next slide. And the next one is the isthmectomy. In this procedure, only the middle portion of the thyroid gland will be removed, which is also called as the isthmus. It is a surgical procedure that excises only the thyroid isthmus. It allows excision of the lesion without exposure of tracheoesophageal groove. Thyroid isthmectomy is safe alternative to thyroid lobectomy with isthmectomy in patients who have nodules confined to the isthmus and pyramidal lobe. Leaving a cuff of normal thyroid tissue has the advantage of not exposing the tracheoesophageal groove, thus minimizing the damage to the recurrent laryngeal nerves and the parathyroid glands. The next one is the total thyroidectomy. In this procedure, the complete removal of thyroid tissue along with the isthmus will be done. Because of this, it will cause the hypothyroidism. A small incision in the lower central neck is required, which is about an inch in the length. Because the thyroid gland is entirely removed, this procedure causes the hypothyroidism. Without the thyroid gland, no thyroid hormone will be released. To compensate this, the patient needs to take the thyroid hormone replacement therapy. The post-operative complications are very high in this procedure, which includes the bleeding and most importantly, hypocalcemia, recurrent laryngeal nerve, palsy, airway obstruction, and the wound infection. Next slide. Next slide. And the next one is the subtotal thyroidectomy. In this case, removing the both lobes, leaving behind 4 to 5 grams of the tissue at the recurrent laryngeal neck. It is mostly done for the non-cancerous thyroid goiter and also for the Graves' disease. In this case, the post-operative complications are very low. Next slide. The next one is the near total thyroidectomy. It is almost done as same as the subtotal thyroidectomy. In this case, the removal of both lobes, leaving the minimal tissue less than the subtotal thyroidectomy will be done, leaving the minimal amount of the tissue around the recurrent laryngeal nerve. As it is the same as the subtotal thyroidectomy, the post-operative complications are very low. Next slide. The last one is the Hartley Dunhill procedure. The removal of one entire lateral lobe with the isthmus and the partial or the subtotal removal of the opposite lateral lobe will be done in this procedure. This will be mostly done in the non-toxic multinodular goiter. Next.
So for the operative techniques of thyroidectomy, there are 3 steps. Let's start with step 1, exposing the thyroid gland. For the positioning of the patient should be supine and with a neck pillow so that the neck would fully extend. For the you'll see here that this is the incision is being marked. This is called the collar incision or curvilinear skin freeze incision. It should be in reference with the cricoid cartilage, which is 1 to 2 finger depth breadths from the said cartilage. With figure 2, this is called the subplatysmal flap. It is elevated from the thyroid notch as the superior border and the sternal notch inferiorly and the sternocleidomastoid laterally. Note that the platysma is not visible here in the midline. In order to do that, in order to find that, it's easier to locate the external jugular vein first, so that it's located beneath the platysma. So next, in the figure 3, you should identify the midline raphe, which is hyoid muscles. So this raphe is divided from the thyroid notch superiorly to sternal notch